When you think about airway obstruction, what signs and symptoms should come to mind? Choking, noisy respirations, stridor, ineffective cough, wet, gurgling noises, diminished breath sounds, difficulty swallowing, severe dyspnea, tachypnea, restlessness, fear, and anxiety. A noisy airway is always obstructed, but an obstructed airway is not always noisy. That comes to mind any time I care for a client with or at risk for airway obstruction. We know that when a client has a tracheostomy for an airway obstruction, it's usually a surgical procedure performed under sterile conditions in the operating room. But sometimes it becomes necessary to perform the procedure on an emergency basis to re-establish airway patency. A standard tracheostomy tube consists of an outer cannula that sometimes has an inflatable cuff, an inner cannula, and an obturator, or guide. We use cuff tubes to protect the lower airway. The inflated cuff occludes the space between the tracheal walls and the tube, thus separating the upper and the lower airways. Pre-operatively, it's important for the nurse to prepare the client for the procedure, to discuss the alternative communication methods that will be used afterwards, and to offer reassurance that the client will be able to breathe through the trach tube. Immediate post-operative care, which you will observe with a client coming into the ICU, includes close monitoring for any signs of complications or airway obstruction. What do you think the nurses will do at this time? They will monitor vital signs, looking for signs of shock or hemorrhage. And since hemorrhage might be internal or external, they would be sure to check behind the client's neck and also for edema, which could cause stridor, dyspnea, or hypoxia. They will also assess breath sounds and note the color and consistency of secretions. At this time, what do you think will be critical for this client and his family? This is the time to provide emotional support. This client and his family are likely to be anxious. It is essential to make sure that the client has a means of communicating, like a call light, a magic slate, or a pen and paper. Other things you have to think about for a client who has a tracheostomy is maintaining that patent airway at all times. You'll do this with several targeted nursing activities. Think it through now. First, you'll suction the tracheostomy as needed to remove excess secretions. You'll wear gloves as you remove the inner cannula and place it into a basin of hydrogen peroxide. Then hyperoxygenate the client either with a breathing bag, also called a manual resuscitator, or via oxygen administration, or both. You'll administer liquefying agents directly into the trachea if prescribed. Then you'll insert the catheter without suction. Then while applying suction for no longer than 10 to 15 seconds, you'll remove the catheter while rotating it. You'll hyperoxygenate again before repeating the suctioning procedure. Once the secretions are removed, you'll cleanse the inner cannula, rinse it with water, and reinsert it. Nurses also change the dressing around the tracheostomy as needed and observe the skin around the stoma for signs for infection. You'll also make sure that the tracheostomy ties are secured and that you have assistance when changing them to prevent tube dislodgement. And, because secretions can cause airway obstruction in these clients, hydration is important, as is oral hygiene. The client and family must be prepared to care for the tracheostomy before they are discharged. You will also provide opportunities for them to practice before sending them home. At this point, I want to discuss a complication that we work very hard at trying to prevent. Any ideas? Atelectasis. Our post-operative clients are at risk for it. Hang in there, we are making good progress with this information, and atelectasis is definitely worth reviewing. Let's start by talking about what atelectasis really is. It is an incomplete expansion of a lung or a portion of a lung, due either to hypoventilation or to obstruction. It is a common postoperative complication. especially after chest or abdominal surgery, but other clients are also at risk. Risk factors include immobility, an inability to breathe deeply, for example, due to pain, respiratory depression from analgesia, abdominal distension, smoking, obesity, respiratory tract infections, and tumors. Signs and symptoms of atelectasis are dyspnea, anxiety, cyanosis, tachycardia, tachypnea, hypotension, fever, pain on the affected side, decreased breath sounds, and pulmonary crackles. Diagnosis is through history, physical, and chest X-ray. Nurses help manage these clients by monitoring respiratory, nutritional, and fluid status. Key interventions are encouraging the client to turn, cough, and deep breathe at least every 2 hours, promoting mobility, helping the client use an incentive spirometer, increasing fluid intake, administering oxygen as prescribed, and performing chest percussion and postural drainage. Sometimes it's necessary to provide pain medication prior to getting clients up or before having them turn, cough, and deep breathe. Remember, clients who are hurting are just not going to want to breathe deeply. Having said all that, which clients are at greatest risk for atelectasis? The elderly, because of decreased numbers of alveoli and decreased functional capacity. We have 2 clients to discuss now, both being treated at our pulmonary function lab. The first is having a procedure called a bronchoscopy. That's an examination of the trachea and the bronchial tree through a flexible fiber optic tube we call a bronchoscope. We perform these procedures on clients to obtain tissue samples for biopsy, to obtain fluid or sputum specimens, or to clear an airway of a mucus plug. Before the procedure, nurses in our bronchoscopy lab make sure that the consent is signed and that the client understands what is going to be done and why, and any risks that might be associated with the procedure. What do you think some of the risks of this procedure might be? Because we are inserting a bronchoscope, pneumothorax and perforation are 2 possibilities. There is also a chance of inducing respiratory distress, infection, and bleeding. Another major risk